Over. Hi, my name's Uzma Samadani, and I'm going to be talking about epidural stimulation for spinal cord injury, which I believe should become the standard of care for patients with spinal cord injury. Thanks for joining, and here we go. These are my disclosures. I do have intellectual property related mostly to brain injury assessment, and I have multiple sources of funding, including Abbott Diagnostic Labs. They do make the stimulators that I will be discussing in this talk. However, all of the funding that I've gotten from Abbott has been purely in the form of devices for IDE trials. I have not actually received any cash or consulting fees from Abbott. So where do we start with? Well, years ago, Dr. Susan Harkema at the University of Kentucky published a paper where two patients who had motor complete spinal cord injury were able to achieve standing. I saw this paper back in July of 2015, and I thought, wow, this is amazing, and we need to try this. So we submitted a grant to the Minnesota State Office of Higher Education, and it was funded on January 8th, 2016. Keep in mind that at that time, I had never placed a spinal cord stimulator for spinal cord injury in order to restore function. And this grant was co-submitted by David Darrow, who was a resident at the time, and myself when we were at Hennepin County Medical Center. We got the second grant funded at the VA, where I'm also faculty, in June of 2016, so a couple of months later. We enrolled our first patient for a spinal cord stimulator on September 27th, 2017. Her name's Kathy Allen. She's spoken out publicly about her experience. She's a T4 Asia A spinal cord injury patient who injured herself sleepwalking in April of 2006. So she was 11 years out from her injury when she received the spinal cord stimulator. And this is some video of her demonstrating the benefits that she had from spinal cord stimulation. And you can see that she was able to do things like improve her thoracic tone and posture to the extent where she could pull herself to a stand. And then she could also, for example, lock her knees and then pedal with her hands, something that she could not do prior to receiving her epidural stimulator. So she had significant benefit from the device and still continues to have that benefit. We were not the only ones running trials for epidural stimulation for spinal cord injury. At the time, there were multiple hospitals doing this. We ended up enrolling 18 patients in the East End trial at Hennepin County Medical Center and the VA before I left Hennepin County, and I'm still at the VA. But UCSD was also enrolling patients in trials, Mayo Clinic, University of Kentucky, and UCLA, and all of these groups reported reasonable successes with their patients who received epidural spinal cord stimulators. We then published our results with our first two patients who were both women and both able to achieve volitional movement after chronic neurologically complete spinal cord injury. Then when we got to 7 patients, we published a paper about those. Of those 7 patients, 4 of them were able to achieve spontaneous volitional movement even after the stimulator had been turned off. This is the results from that second paper that we published on East End. And you can see that there were 7 patients, the majority of whom were Asia A, all of whom had thoracic spinal cord injury, who had various mechanisms of trauma, and all of whom had their stimulator placed at the level of the conus approximately. And these are their MRIs. And what's remarkable about this is the heterogeneity of injury. Some patients appear to have significant myelomalacia with cystic cavities in the spinal cord, and it's even not apparent that they have continuity of their spinal cord. And other patients have relatively preserved appearance of spinal cord with less myelomalacia. And what's interesting about this is the fact that there did not appear to be a strong correlation between the radiographic integrity of the spinal cord and the outcome after spinal cord stimulation. So the 3 best responders in this study were patients who were able to achieve volitional activation of multiple muscle groups in the bilateral lower extremities. So what you're looking at is on the first column of these 2 tables is the month follow-up. So the patients were following up for 1 year. And then each colored box indicates an area where they were able to achieve movement in a muscle group. For example, plantar and dorsiflexion of the foot, extension and flexion at the knee, or extension and flexion at the hip. And what you see is with the stimulator off, which is table A, the patients were able to achieve some level of activation. But with the stimulator on, they were able to achieve far more significant level of activation. And subject 3 was able to achieve substantive activation in nearly all muscle groups of the lower extremities. The gray boxes are visits that the patients were not able to attend due to the COVID problem with the pandemic at that time. So we wrote another paper about the first 4 participants that basically showed that they were able to voluntarily cycle after motor paraplegia, even after the stimulator had been turned off. So here is the patient. This is subject 3. So this was one of our best responders. And when he has the stimulator off, he's able to move the fast bike and create volitional movement in his legs, even though he was previously an ASIA person. So you can see significant improvement in activity there. This was the first E-stand patient from the VA. So this was a gentleman who, he's been public about his injury. Again, his name is John Lee. And what he was able to achieve very early after the stimulator was placed was flexion and extension at the knee. And you can see him doing it volitionally there. And then because of his stimulator, he was able to start using an exo and standing and walking with the exo. And he got up to being able to walk about half an hour at a time, which he posted on, I think this was Twitter. So you can see that he achieved some significant benefit with the spinal cord stimulator. And the people who are helping him in this video, that's Elizabeth and Anne. They are physical therapists at the VA. And you can see that they're literally changing the stimulation parameters in order for him to achieve his goals. So of the first 18 research devices that we placed, we had volitional movement in almost all patients. We had spontaneous volitional movement in at least half of them. We had improvements in bowel emptying, bladder capacity, and sexual function, as well as improvements in spasm, neuropathic pain, and back pain. And we had better blood pressure and temperature control that patients reported. So overall, I would say the trial was a success. But what happens next? What can we offer people who are unable or ineligible to commit to E-stand or other trials? And why are they unable or ineligible? Well, either because they have a higher level of injury, higher than C7. So E-stand was designed for C7 to T10. They have a penetrating trauma, such as this gunshot wound. They have non-trauma. They were a tumor, hematoma, demyelination, abscess. The extent of their injury is less. We targeted the E-stand trial at patients who were basically ASIA, or they have the inability to make a time or relocalization commitment. So we required 13 visits to Minneapolis over the course of a year in order to participate in the E-stand trial. And this requires significant finances on the part of the participants in the clinical trial. Even though we pay for some aspect of the visit, we obviously didn't have the funding to pay for the whole thing. And many patients cannot afford to take time off work or have a family member take time off work to travel or to pay for housing in a different town. And so this is a very unfortunate circumstance, and it makes us wonder, is there anything we can do for these patients? So, and it also raises the question of, is the use of spinal cord stimulation off-label in patients with spinal cord injury? So if you look at the FDA marketing authorization for the spinal cord stimulator device, the indicated use is complex regional pain syndrome. Patients with spinal cord injury were not included in the pre-submission or the pre-market approval for the spinal cord stimulator device. What this means is that spinal cord stimulation is approved and indicated for complex regional pain syndrome, but it was never specifically tested in patients with spinal cord injury. That does not mean that patients with spinal cord injury cannot receive the device. It just means that Abbott cannot market specifically for patients with spinal cord injury or to improve outcomes after spinal cord injury. So it's not technically off-label or not indicated. It's just never been formally included as a subset of patients who participated in the pre-sub. So do patients meet the definition for complex regional pain syndrome? Well, patients with spinal cord injury do meet this definition because, number one, they have sensory loss. They have typically hypoalgesia and hypoesthesia below the level of the injury. They have trophic changes in the skin. They have autonomic dysfunction, including GI dysfunction, and both bowel and bladder dysfunction, GU dysfunction. They typically have inability to achieve ejaculation and ejection if they're male, or orgasm if they're female. They also have motor weakness. They have contractures and atrophy below the level of the injury, and they often have neuropathic pain and spasms. So the patients do meet the definition of complex regional pain syndrome type 2 secondary to spinal cord injury. As a result of this, we have achieved a reputation where patients come from all over the country, and we've had patients come from 20 different states to have a spinal cord stimulator placed for spinal cord injury. And what we see is that these patients are doing incredibly well. This is a patient who traveled to me from California. She's been public about her injury and her identity. And you can see that she's able to achieve significant gains with the spinal cord stimulator. She was initially ASIA immediately after her injury. She had a C7 injury. She recovered spontaneously to ASIA B. She was implanted September of 2019. And you can see that she's able to not only volitionally move, but she's able to lift weights with her legs with the spinal cord stimulator on. And then here you can see, and I don't think this is a video, you can see that she's walking, which she posted on one of her social media websites. And she's continued to show significant advances after having her spinal cord stimulator placed. This is the same patient, and I think this is that was a video. Well, she had posted the videos of herself getting in and out of a bench chair, standing up, working on stand pivot transfers with her stimulator on. Here's another example of a patient who would not have been eligible for the eSTAND trial. This is a 20-year-old. He was a football player that was shot in the spine on April 23rd, 2017. It was a random shooting. He was not the target, and he had this gunshot wound to his spine. He came to me when he was 25 years old, so 5 years after the injury, T6 level Asia A spinal cord injury. And then he wanted a stimulator. And obviously, when he had this large bullet in his canal, I had some reservations about placing a spinal cord stimulator without first addressing this. And obviously, there was not thought at that time to be an indication for surgery. But once you decide that you want to place a stimulator, then it seems that surgery might be a better solution in order to remove any metallic objects that would impede the function of the stimulator. So we made the decision to do a two-stage operation. The first stage would be to remove the bullet, and the second stage would be to place the stimulator. So this is what the bullet looked like after it came out. This is what his post-op CT looked like after I had removed the bullet. And obviously, because of the amount of bone that was impacted, I decided to perform a fusion in addition to the bullet removal. This is his spinal cord stimulator. And this is now the patient. Here he is on approximately post-op day 1 or 2. And you can see he's moved from being Asia A to being able to move his legs. And he has some additional flexion and extension in his lower extremities. And then here he is. Here he is practicing stepping with his epidural spinal cord stimulator. And you can see that he can kick his legs. He can't control them very well, but he can still kick them. And then here he is working on standing. And this was something he could not do prior to getting the stimulator because he was not able to lock his knees. But now he can do that. And obviously these patients have a level of resilience that's just extraordinarily high. He was a serious college athlete. He now is for the police department. It tells you what kind of person he is, that he's this tough and able to do things. So let's to some of the early results of the 23 spinal cord injury patients who had thoracic spinal cord injury. 15 of them were responders. 8 patients were non-responders. And by responders, I mean that they saw some improvement in function. So 5 of them were working on walking, multiple were working on standing, many had improvement in core strength, bladder capacity, bowel emptying, spasticity, improved sleep, sexual function, and pain. Of the 25 patients who had cervical spinal cord injury, 17 of them were responders. The others were non-responders. 3 had the device removed, and 5 were complete non-responders. And we can talk about what makes for a risk factor for a non-responder. But 4 of the cervicals were walking, multiple were standing. Many had improvement in core. 1 had improvement in arm and hand function, which is above the level of the spinal cord stimulator placement. Bladder, bowel, spasticity, sleep, arousal, pain, and quality of life were all improved. Of the approximately 73 devices I have placed clinically for complex regional pain syndrome type 2, 5 have been removed. 1 of those was reinserted. 2 were removed due to infection. 1 patient was transiently worse post-procedure. 1 had skin breakdown, and so there was concern that the device had to be removed. 2 devices were non-effective. 2 have migrated and required revision. So what are the barriers? Number 1, I would say there's a perception that insurance will not cover this. That has not been the case for me. When I first started doing this, I often had to do peer-to-peers. I no longer have to do any peer-to-peers. The insurance companies have been covering this with no problem. The FDA is not an issue. We meet the definition of complex regional pain syndrome type 2 secondary to spinal cord injury. And so this has not been an issue at all. I'm always shocked to find out that patients are paying cash for a spinal cord stimulator because the majority of my patients have not had to. The only patients who have had to pay cash in my practice are the ones who have state health insurance, like Medicaid in their home state, that won't cover care out of state. I also have a patient who I'm currently talking to who has Kaiser Permanente, and they will not place this kind of stimulator. And so he may come out of state and pay cash. So a couple of people have had to pay cash because their network doesn't allow them to obtain care from a different provider who's out of network. And that's obviously a problem. But for the vast majority of the patients, I would say 95%, they've been able to get insurance to cover it, no problem. What are the other barriers? There are infection or skin issues. Many of these patients, because they are quadriplegic or paraplegic, have had flaps or have had decubitus ulcers. And so that becomes a problem that you have to be aware of. There are positional issues where if the patient is very tall and thin, when they flex or extend at the waist, they can move the stimulator so that it's flush up against the spinal canal or not. And so what I've done is when I have a taller, thinner patient with less stenosis in their spinal canal, I'll often put a little extra ligamentum flavum or fat tissue into the epidural space to hold the stimulator in place so that it doesn't become positional. I would say the other barrier is optimization of programming. So that I think is the single greatest barrier to widespread implementation of spinal cord stimulation for patients with spinal cord injury. Because there are so few people who are able to do the programming for these patients, both in the operating room so that you can achieve appropriate placement and postoperatively, that's something that definitely needs to be improved. And then finally, I would say the last barrier for these patients is many patients have not been participating in standing frame or lower extremity strengthening exercises or mobility exercises for the duration of their paraplegia or quadriplegia. And as a result, they have poor bone density, they have loss of muscle mass, and they have unstable joints where their joints have become fixated. And so we have actually seen multiple patients develop problems in the lower extremities, like where they'll go to start walking and then they'll fall and they'll break something. And so this is something that we have to be very, very aware of, is that these patients often have significant osteopenia and sarcopenia and joint basically rigidity and adhesive capsulitis as a result of their condition. The surgical technique is very simple for this. I use a Jackson table with a Wilson frame, a C-arm, general anesthesia with no paralytic. For the vast majority of thoracolumbar stimulator leads, I do the LAMI at T11-12. Most of the leads sit on the conus at L1-2. I use monitoring. We do monitor almost all the muscle groups of the lower extremities. I want to be midline radiographically and electrophysiologically. So when we turn the lead on, we want it to stimulate the muscles in the bilateral lower extremities, isolating right and left, and mapping all muscles independently. Taller, thin, young men who have larger spinal canals are more likely to be positional. They have less epidural fat. And so you do have to place a little fat or ligament into the epidural space to hold the lead flush against the thecal sac. To avoid lead migration, I loop it, I place a tethering suture, and I put a shorter distance between the IPG and the lead. You can use an abdominal binder in patients who are very wiggly. We've done a week of prophylactic antibiotics. We did that for the eSTAN trial, and then we decided to continue it in the clinical patients because the one patient who didn't take it, and this is purely anecdotal, was one of the patients who got infected. So as I said, patients have come from all over. This was one of the first patients I did in private practice. And she was able to achieve stand pivot transfer. Here's another patient from Illinois who was in Israel. This is that same patient I showed you from California. This is a skiing accident patient from Colorado. He was Asia B. Okay, let's go next. And then this is, let's see, does this video continue? This is another skiing accident from California. And he can stand with the stimulator. You can see he's got his programmer sitting next to him. This is a kid from Minnesota who was in Asia A, swimming pool accident. Another kid from Iowa.
Give you freedom, give you fire, give you reason.
Oh, this is a C1 injury. She had a stimulator placed with T11-12, and she improved her ability for pronated supinated hand after the stimulator was placed. So this is kind of interesting because it's actually above the level of the injury. And then let's see here. This is a gunshot wound to the spine that was 11 years out from injury. And he was Asia A. He had improved to Asia B on his own, and then we implanted the device in December of 2023. And look at him kicking that leg. So he was able to achieve walking, which is pretty impressive, considering he's 11 years out. So as I mentioned, one of the challenges is the stimulation parameters. So we have created a website called pulseshare.org for patients to post their stimulation parameters. And this is what it looks like. So if a patient, sets their anodes and cathodes in particular arrays, and then their pulse width, their frequency, the frequency pulse width, the amplitude is recorded, and therefore they can share what they're seeing in terms of stimulation parameters that are useful for them with other people. And for the most part, the patients actually can't see themselves what their stimulation parameters are, but the physical therapists and programmers can. So we want them to share, and that's been one of the biggest challenges is having people share their stimulation parameters. This site is free, it's patient and physical therapist directed, it's rapidly updatable, and we hope that everyone will use it. So I think that what our data suggests is probably complete as we think about it. Spinal cord injury does not really exist. All spinal cord injury should be treated as recoverable. Um, People should be treated early, and things that are in the canal should probably be moved from the canal at some point. And it raises a lot of questions. Can we do epidural stim without decompressing or removing a bullet? I think it's probably better if the spine is decompressed and the bullet is removed. What's the timing? I would say let's do it before the loss of bone density and muscle mass. The pros of spinal cord stim are improved sleep, reduction in spasms and pain, improved bowel emptying, bladder capacity, sexual function, is relatively low risk. It's an outpatient surgery. It takes about 1 to 2 hours and it can be turned off. There are obvious risks. The risk of CSF leak is one of them. So, there are known risks, but I think for most patients, the benefits far outweigh the risks. And even though there are a significant number of non-responders at this point, I think that's more of a programming problem, and that those patients would respond if we were able to get the appropriate programming. So I do think that it should be standard of care. I think every spinal cord injury should be treated as potentially recoverable. There should be rigorous decompression and adequate fixation, early surgery to reduce the secondary effects. There have been some literature to suggest that duroplasty may be a solution. It should be done early, as soon as possible after the spinal cord injury, and then the patient should have ability-based physical therapy that should be covered by insurance, and that should be standard. And this is a patient, Yvonne Deere. She basically has been public about her injury as well, and I placed a stimulator in her. She was Asia A, and here she is standing up in her kitchen. To me, these are significant victories. I'm just thrilled to see my patients doing this. I want to thank my collaborators. This takes a team, obviously. The rehab people that I work with are a couple of gyms. One is based out of the Chicago area, Tri-Ability Rehab. One is based out of the Southern California area. That's Renew Health. Chris, Krista, and Micah are there. And obviously at the VA in my hometown, Elizabeth and Ann have just been amazing collaborators for us. And Carrie Chang, her name's not on the slide. She's the rehab doctor that we work with. And we've had a lot of private donations. We've had state funding. We've had devices from Abbott and funding from the state government. So, we're very grateful for all of that. For questions, these are my numbers. Thank you.